Thank you. Thank you to the moderators, and above all, thank you to Manos Brilakis and Antonio Yanakis for the kind invitation to do this amazing course. And so let's still talk about shoulder instability with bone defects and how to fix it. These are my disclosures. And let's go first to what everything agrees, that if we don't detect bone defects and we do soft tissue repair, we have bad results in terms of recurrence rate. And this is everybody agree about the inverse relationship between the stability and the size of the bone defect, especially if we have to face a bipolar bone defects. So it's important, in my opinion, to have a diagnostic algorithm. So ask for a AP view on X-ray. If you see a lossy contour of the glenoid, then do a CT scan and measure the glenoid defects, and if possible, detect the position of the Hill-Sachs lesion. And then here stops the agreement between people, between surgeons, because we have seen we have so many options, and still is too late to know what to do. And so there's still a question mark when to do soft tissue repair, 10% of glenoid bone defect, 15, 25. Still, we don't know. Everybody has his own algorithm. And then which kind of bony procedure? Because until recently, we heard about Bankart and Latarjet, but we know now that we have more options. And I think all these options, they have a slightly different indication. Of course, we have to take in mind that it's not 20 or 25% of bone defect in the glenoid cutoff for having a bony procedure. It's much less. But as I said, there is no consensus. Many years ago, I think I published this in 2012. This is my treatment algorithm. Maybe I added just the ISIS correlator, but I think what is important is the number of dislocations when we have the bone defects, and also the history of the patient. Because if we want to do a reconstruction of the soft tissue, we have to keep in mind that if this guy is unstable for many years, he has a plastic deformation of the ligaments. So even if they look good, probably they're not good in terms of stability. And so this is a classic case where I have to face when I see a guy coming with an unstable shoulder. This is quite young, involved in sport, 1.5-year history of dislocations, of instability, and 3 episodes. About 18% of glenoid bone defect in a Hill-Sachs lesion. So for me, this is a perfect case of bone block procedure because it's not a very old history of instability. And I started this and I presented this in 2005. The first cases actually I did in company of my friend Enrico Gervasi, and then I did it myself. We were using at that time an ACL guide from posterior portal, since there were not guide for drilling posteriorly the graft. But nevertheless, we were quite able to place the graft in a proper position, very flush with the glenoid rim. Of course, if you come anterior and you do that using screws, often you are oblique, you don't have the perfect direction of the screw. So this was a challenging procedure, not risky actually, but challenging, and with some critical steps. And since I was believing a lot on this technique, thanks to Smith & Nephew, we have developed and we have increased and make it simple, the technique. We use a guide that is very similar to the one that Pascal designed for the Latarjet, with the same concept, 5 millimeters offset of the bony tunnel. Here there are 2 bony tunnels, 1 centimeter apart. Using the posterior guide, we are sure that we're drilling 2 tunnels perfectly perpendicular to the glenoid neck, which is made flat arthroscopically, and with a perfect offset of 5 millimeters each. And then passing through the rotator interval, so no dangerous or difficult portals with cannulas designed for this technique. We introduce the graft that is going to place exactly where it should be, where there is the bone defect, with the same offset of the holes pre-drilled in this technique. I think, since I did that for a long time, we have made a patent, a US patent for this technique, since we were the first doing that long ago. And this is the technique, how is it now? It's a classical shoulder arthroscopy with no funny portals. We have just a posterior portal for the scope, 30-degree scope, a mid-glenoid cannula, and an anterosuperior cannula. And as for any Bankart, we release accurately the labrum and the ligament. And since I'm doing that since a long time, I've used autograft, allograft, but recently, like Maiotti said, and later probably Raffaele Russo showed us, we're using equine bone, horse bone, because, is already prepared for this technique, is ready to use, and, he has a very interesting characteristic in terms of resorption and stability. Here you see we use the guide, we drill 2 tunnels, we introduce a 10 millimeters cannula, actually 12 millimeters cannulas through the rotator interval in order to let pass the graft, which is 1 by 1 by 2 centimeters, which is the average of all the coracoid we harvest from our body. We load with 2 couples of round end buttons the graft, and pulling and releasing the 2 shuttle suture, the graft goes almost automatically into place, and having 2 couples of round end button make that maneuver easier because this graft doesn't rotate that much like with only 1 couple of round end button. It goes there, flush where there is the glenoid rim and when there is the bony defect. We make the nice knot and we fix with 2 posterior buttons with 2 holes instead of 1, and then we tension in the same way Michel showed for the lateral J. Just that on top of that, we reconstruct the capsule and the ligament, and if you pick the patient, select the patient with the characteristic I said, this is a very effective technique. So how it works? Works where we restore the bone damage, placing a bone graft very nicely, very flush with the glenoid where there is the bone loss. And on top of that, we reconstruct the capsule and the ligament. And as you can see here, the graft remains an extra-articular platform to support our Bankart repair. In my opinion, this should be called Bankart Plus. There is Bankart plus the bone, so anatomical reconstruction of an unstable shoulder. And remembering, the algorithm for looking for this patient, I published data, and if we pick this patient with this characteristic, we have a very good recurrence rate, which is less than 2% in this series. And looking at the CT scan, we are very happy about the positioning of the graft, because thanks to the guide, we are able to place exactly where the bone defect is and flush with the glenoid rim. And so this is an anatomical reconstruction of an unstable shoulder. These results, actually, they are not achieved just by ourselves. Manos group and other people, looking at the literature, show that this technique can be effective in this patient. And so I would say that compared to soft tissue repair, this technique has a lower recurrence rate, especially when we treat patients with bone defects. And is an anatomical reconstruction of bony and soft tissue lesion. In my mind and in my practice, bone block and lateral J have exactly the same indication. So there is not bigger bone loss, bipolar or bipolar. The only difference is the quality of soft tissue. And I've decided many years ago that chronic cases, more than 2-3 years of instability, they are no good for bone block alone in the way I showed you. And so these people, they need the action of the conjoined tendon if there is a longer history, or the subscap tenodesis or other non-anatomical technique. In any case, when we have faced a patient with this characteristic, where Bankart is not a good indication, and lateral J for me is an overtreatment, I think bone block is a viable alternative because it's anatomical, there is no tendinous transfer, no subscap split, and it is not a challenging and difficult procedure. Very quickly, looking at the graft, we have published this. We have compared the lateral J using screws and the buttons, and the bone block using allograft and xenograft. And the interesting thing is that we found that all the data about the CT scan, the best results is the bone block with the equine bone, the horse bone, and the worst results are for Latarjet using screws in terms of osteolysis, osteointegration, and what is significant difference, the complications. We found more complications just relating to the CT scan with Latarjet than bone block. So in conclusion, I think that all the time we should look for, personalization, as was said by Chiara Fossati for the treatment. I think that if we look at all the data, people with bone defect and not a long history of instability, they are perfect candidate for a bone block, so anatomical procedure. As I said, this is something that restores the regular anatomy, bony and soft tissue. It's safe because the portal has really classical portals. It's really reproducible because when you learn how to place the posterior guide, all the procedure is done, and is effective because we have a very low rate of instability, of recurrent instability. Thank you very much for the attention.